Go.
Good evening, everyone, and welcome again to a clinical webinar on CEC channel. Today, we are going to discuss the updated edition of non-STEMI guidelines that was released by the European Society of Cardiology at the last European Society of Cardiology Congress, which was a virtual congress. So we are going to discuss these guidelines with great cases prepared by brilliant speakers. We have today among us Dr. Moheb Magdi, the lecturer of cardiology at Mansoura University. And also we have Dr. Omar Saleh, the lecturer of cardiology at Suez Canal University. This will be with the moderation from Dr. Karim Saeed, the professor of cardiology at the Cairo University. So let's enjoy the great case of Dr. Moheb Magdi and the approach to non-STEMI patients according to the recent guidelines. Dr. Moheb, please share your screen.
Thank you, Dr. Karim. And actually, it's a great pleasure to be with you all in the CME Egyptian Society group, and it's an honor to be with you all. Today, we will talk on an approach to the guidelines. I have a case of a male patient, 55 years old. He's a smoker 20 years, and he is a hypertensive 8 years ago and under medical treatment, but not diabetic. He presented to non-primary PCI capable center with typical ischemic chest pain, 2 hours duration, and his blood pressure was 90/60, heart rate about 125, and he has a bilateral basal crypts. So his ECG show nothing but sinus tachycardia, no ECG changes in this ECG. So according to the recent guidelines, we have to integrate all the approaches, and actually this scheme help all young doctors for diagnosis. I have to first search for the clinical setting and the type of chest pain. And as we see here, if we go further with the typical diagnostic criteria of chest pain, the risk increase from low to MI. And of course, we have to check for presentation of CPR and shock because the patient may come in cardiac arrest. And of course, the ECG will be variable in the acute coronary syndrome between normal and ST elevation, and of course the troponin level at 0 hour and troponin level again at 1 or 2 or 3 hour will differ according to the situation or the setting of acute coronary syndrome, and then the triage, the decision of rule out myocardial infarction observed, as we will see in the next slides. And again, the recent guidelines add to us what we call the effective high sensitivity troponin assay. And if you look at this slide, we will see the difference between the conventional assay by microgram per liter and the high sensitivity assay by microgram per liter, because we have a large area of uncertainty of the conventional assay of troponin. It's likely to be boosted by the high sensitivity troponin assay. That's why we have to use the high sensitivity troponin assay in all our labs for the what we call the rule out and rule in rapid detection or rule out of MI. And if we look at this new, no, it's not new, it's a repetitive conditions which increase the cardiomyocyte injury and lead to elevation of cardiac troponin, which mimic the myocardial infarction and non-STEMI in this situation. The tachyarrhythmias, heart failure, the hypertensive emergencies, myocarditis, subo, valvular, anything that affect the heart and the red will lead to increase in troponin. And we can add on the renal dysfunction, the stroke, cardiac contusion, and procedures like BCI and CABG. And the hypo and hyperthyroidism can change cardiac troponin, infiltrative diseases, and myocardial drugs toxicity, and extreme endurance efforts that lead to also increase in troponin level, and finally rhabdomyolysis. What we have here in the rapid algorithm, which exclude or include the myocardial infarction, we have caveats. Caveats include that the algorithm should only be used in conjunction with all available clinical information, including detailed assessment of chest pain and characteristics and ECG. So you have first ECG and then, chest pain and then ECG, then you have to use your algorithm. And also due to the time dependency of troponin release and the only moderate number of patients presenting less than 1 hour after chest pain, especially in our country, So obtaining an additional cardiac troponin at 3 hours in patient presenting less than 1 hour is usually important towards rule out to be considered. And at late increase in cardiac troponin level, yes, we have at least 1% of patients who have a late, they are what we call that increasers, because the troponin level increased lately. So we have to do a serial cardiac troponin testing also if the clinical suspicion remain high, although it is negative in the first hours. If I have a high clinical suspicion, that's a caveats of the rapid algorithm. And we have also in the new guidelines what we are calling confounders of troponin concentration. Yes, the confounders, the age, and of course, due to the pre-existing cardiac disease and renal dysfunction, because it affects mainly the heart and lead to a cardiac disorder. And the time from chest pain to onset, the time is variable, and maybe the time is confusing. And of course, sex male differ than female, and that lead to differ concentration of troponin and lead to confounding results. If we get back to our patient, we have a CK220, CKMP65, high sensitivity troponin assay was 50 nanogram per milliliter, and he presented 2 hours from the chest pain onset. So our patient is ruled in or ruled out. Of course, according to this slide, our patient is ruled in model, and we have the diagnosis of non-STEMI, non-ST acute coronary syndrome. But don't forget the recent guidelines said now, beyond the diagnostic rule, the high sensitivity troponin, it's not only for diagnosis, it's important for prognosis. The more troponin you get, the more the worse case scenario of the patient, either during in hospital mortality or 6 months post MI. And the guidelines add measuring the BNP or BNP plasma concentration at the time of diagnosis maybe have a prognostic information in the non-STEMI patient. And it consists of the guidelines give a class 3 indication now for use of other biomarkers like the CT and CKMB and C-reactive protein and the other biomarkers in order for either diagnosis or prognosis. The studies, a lot of the years, over the past years, they did their best to include another biomarker other than troponin, but all failed in front of the sensitivity of the high sensitive troponin. And this what we have the criteria or the chart for rule in or rule out model. If we have at 0 and 1 hour high sensitivity troponin low and normal, we may rule out the MI, and if we have it high, we may rule in. And if we have in between results, we have to observe. And if we have a rule out model, then we either discharge the patient or getting him into the ward and do another test, either for stress testing or the coronary CT or angiography, or if the patient is ruled in, of course, I will do angiography and echocardiography in after admission to the CCU. So, yes, Dr. Karim.
Yes, after finishing these slides, let's get in depth into the rule out and rule in rule, because a lot of us get confused when observing this slide. So you think first thing, I think we should know what is the kit for high sensitive troponin used. Do you agree?
Yes, of course, because not all our labs they use the high sensitivity troponin, especially in the general hospitals and in the university hospitals. It's somewhat expensive, and I hope that one day it's present in all the hospitals. Yes, we are mostly use a conventional assay, and like we see in this slide, very large area of uncertainty present when we use the conventional assay, and it mostly is pathological, but that lead to late in the diagnosis. And as regards the rule in, rule out, like you said, it's simple. We have to take a troponin level if we have the high sensitivity troponin at 0 hour at the presentation, and then 1 hour. And if we have both increasing titer of troponin in these two samples, yes, we will rule in the patient. And of course, it would be above the diagnostic criteria like in the previous slide, like this. And if we have a low or very low high sensitivity troponin at both samples, we may rule out the patient. But we have what we call the 3-hour high sensitivity troponin plus echocardiography. And like I see in this chart, if I have some sort of uncertainty, like I said in the caveats before in the slides, if I have a more clinical suspicion of the patient, because we have what we call the late troponin increaser. Yes, the patient may present and the troponin increased lately. So if I have a high clinical suspicion because of the chest pain, because of the ECG changes, I may wait for another 3-hour high sensitivity troponin, and I use echocardiography in order to make my decision comfortable, either to discharge the patient or getting him to the ward under observation, or even rule in the patient in the CCU and doing the angiography and echocardiography.
So very nice illustration, Dr. Moheb. So I think we should depend on the clinical presentation of the patient first. The patient should have chest pain, ECG changes, whatever, and combining this with the results of troponin.
Yes.
If the troponin is high from the start above the 99% percentile of the our level, our normal level, so we can rule in this patient into non-ST acute coronary syndrome. And if not, if the level is low or if borderline, we should have at least 2 samples, and guidelines stressed or focused on 0-1 hour algorithm.
Yes.
Do you agree, Dr. Moheb?
Yes, of course, definitely.
The next point is that the guidelines, I think, mentioned that we should obtain the 2 samples of the troponin at a 0 hour and 1 hour, whatever the results are received or not. So if we still the result of the 0 hour is pending, we should obtain the results at 1 hour.
Yes, because of the rising titer. Yes, if I didn't get the zeros yet, yes, I will get the 1 and compare both of them later. If the 0 appear later, if they have a rising titer or something, yes, I may roll in the patient.
Okay. And 3-hour troponin is left for clinical suspicion in addition to imaging.
Yes.
So if you still have an addition, if you didn't have a confirmatory result, and after 3 and you are suspecting that this patient have still acute coronary syndrome, you can do a 3-hour cardiac troponin to rule in or rule out the patient into the non-STEMI diagnosis.
Yes, and that's one of the caveats of this rapid algorithm, but it's okay. Yes, everything is not confirmed yet, and the guidelines is trying to improve itself all over the years.
Okay.
So if we proceed with our patient, it's a rule-in patient. Yes, we have a non-ST acute coronary syndrome, and then we like the patient said, and we have what we see now. A segmental wall motion, abnormality in the septum, in the anterior wall. It's definitely important in diagnosis. Yes, because the echo rule here is that we have a segmental wall motion in the LAD territory, and not in this patient, it's important to diagnose the segmental wall motion with. And it's very important to take the ejection fraction and the cardiac function, and of course help in our differential diagnosis if the patient is not having an acute coronary syndrome. And we may use another echo modalities like the contrast echo and the strain imaging, and the guidelines said at this part repetitively, it may help in improving the diagnosis of segmental wall motion, especially the new modality of strain by the criteria of strain and strain rate. We may have something may appear in the strain imaging, not appearing in the eye-pulling in segmental wall motion. And about stress imaging, yes, I have a higher diagnostic accuracy if I use the dobutamine stress imaging for this kind of patient. If I don't have enough criteria of diagnosis of ischemia and I have a high clinical suspicion, and before I put the patient on the rule-out model, I may use a non-invasive test like the stress imaging. It has a high diagnostic accuracy, and I will not forget the higher rule of the cardiac MRI, because it have a higher sensitivity, but it's also expensive in detection in the ischemia and wall motion abnormality and myocarditis, and help in differential diagnosis, of course. And of course, let's not forget the old SPECT. And now we have the coronary CT is a must and +1 indication for low to intermediate pre-test probability patient, like we will see in the red lines in the next slides. Before we proceed to the next slides, we have to not forget about the differential diagnosis of ACS. Not all patient having an acute chest pain is an ACS. We have to consider the cardiac causes like the pericarditis and myopercarditis, the acute heart failure, hypertensive emergency, and Takotsubo, coronary spasm. Don't forget the pulmonary embolism. It's very fatal complication. If I have normal ECG, I have to suspect pulmonary embolism. I have to suspect pneumothorax. I have to suspect aortic dissection. These are the fatal chest pain or causes of acute chest pain. Yes, I have to suspect them. Don't forget, use the cardiologist in the during the ICU, in the intensive care. You have to suspect another causes of acute chest pain other than myocardial infarction and NSTEMI. Yes, you have to exclude aortic dissection, pulmonary embolism, and pneumothorax, and other non-fatal factors like esophagitis, reflux, spasm, gastritis, cholecystitis. Yes, I have musculoskeletal disorders, of course, and the muscle injury, costochondritis, and even tumors. And don't forget the anxiety disorders, herpes zoster, and anemia related to acute chest pain. So as regards red lines in imaging, we have the echocardiography is mandatory after following immediately 12 lead ECG, and it's +1 indication. And if you have a normal ECG finding and normal levels of cardiac troponin, but still I have a high suspicion of ACS, I have to do a non-invasive test or a coronary CT angiography before doing an invasive approach. So this is very important, clear message. If I have a normal ECG finding, I have a normal level, troponin level, but still I have a high suspicion of ACS, I have to do non-invasive test first, preferably with imaging like dobutamine stress imaging or coronary CT angiography. And don't forget that echocardiography is very important to evaluate the regional and global LV function, to rule in, rule out differential diagnosis, and we have to +1 indication to do a coronary CT angiography in a patient with low to intermediate likelihood of coronary artery disease, and when the ECG and cardiac troponin is normal or inconclusive. Yes, that's a new indication in the recent guidelines.
Thank you, Dr. Mohab. I think the part of imaging is very important. Can you share your slides again, please?
I will. Okay.
The role of imaging is very important in the diagnosis of non-STEMI. Talking about the echo is important at every step, but the timing of the echo is very important. If the patient is with a hemodynamic instability or cardiac arrest, as you mentioned, we should have the echo immediate to rule out the mechanical complication and to have an idea about the LV function. However, if not, the patient should have an echo as soon as possible to evaluate the global and regional function, as you have mentioned. So my question now, with the use of high sensitive troponin, Dr. Mohab, and with the patient presenting with a picture of non-ST acute coronary syndrome, some patients will have a normal high sensitive cardiac troponin. You mentioned that this patient will benefit more from non-invasive tests. However, when I want to know your experience regarding invasive coronary angiography with this patient, what would you usually find in the patient with a normal ECG and the normal troponin presenting with non-ST acute coronary syndrome?
You mean after confirming diagnosis of non-STEMI? Yeah.
No. Sometimes we decided to go directly into before these guidelines into the invasive coronary angiography. Yes. But we have a normal ECG and normal enzyme. The term of unstable angina that we have faced it a lot. So
yes. Actually, it's fading. Yes, you know, the term unstable angina, actually after these guidelines, if you are agreeing with me, it's fading, it's disappearing. They confirm now that we have a myocardial infarction or not. I think the guidelines said to us now, if you have a patient with a high suspicion, yes, go for it. But if you don't have a non-invasive, for myself, if I don't have a non-invasive stress testing like the dobutamine stress or coronary CT, yes, I will go for invasive approach, because sometimes we discover something like spontaneous coronary dissection and coronary spasm may induce the acute severe chest pain, and sometimes it's not giving a normal ECG, but it's in the guidelines, recent guidelines, they said to us you have to do a non-stress test. This has some sort of a wide variety of experience between operators or between cardiologists, because it differ about the high suspicion of chest pain. For me, myself, if I have a very, very high suspicion of the chest pain and high risk criteria for the patient, if he's diabetic, hypertensive, or smoker, or family history, or dyslipidemic, or whatever, and I will have some sort of delay in doing the delayed non-invasive stress testing and coronary CT angiography, yes, I will go for angiography, an invasive approach, but it's not the rule. You have to be an expert, and you have to see a lot of cases. You have to suspect the unexpected, because we see a lot of young people presenting with vasculitis and coronary spasm and spontaneous coronary dissection. And I think you agree with me in this type of scenario.
So I agree with you. The rule, if you have patients, especially a female patient with a normal ECG and normal cardiac enzymes, and you have the access to a good non-invasive test, so it will be better, whatever it is, a stress imaging or a CT. So we have a burning question about.
So we have. Go ahead, Karim.
I got it, Haitham. It's about, we have a burning question from two of our colleagues, Dr. Hagar Mustafa and Dr. Muhammad Abdullah, about the role of stress testing in the acute coronary syndrome and the safety of stress testing in the acute coronary syndrome. What do you think, Dr. Muhammad?
Yeah, of course, it's as we see in this slide, it given the stress testing class 1 indication in the patient with normal ECG findings and normal levels of cardiac troponin first. Yes, we have a hemodynamically stable and normal patient with just nothing but chest pain. And if we see the previous slides of the rule in and rule out, yes, we have to do either the patient for discharge or giving him some days in the ward. And I think if we delay the diagnosis for 1 day after stabilizing all the condition, I think that we have a stable patient with normal ECG, with normal troponin. Yes, I will do a stress testing without any contraindication, and it's safe and it's easy. Yes, and it will be in the hospital under your observation. And it, like we said, it's some sort of, we have some sort of criteria like the normal ECG and the normal troponin level. And in the same time, the guidelines give us, if we don't have a high suspicion of ACS, we may discharge the patient, and it's a rule out criteria. It's a non-cardiac chest pain.
So,
okay, Dr. Muhib, there is another question. With the risk stratification of the patient, intermediate or low risk, we can end if the troponin is elevating at 1 hour or 3 hours to go to coronary angio or stenting of this patient, even if they have a low or intermediate probability with depending on the change in the troponin. So this is the only dependable factor, or do we have to risk stratify the patient using another score like GRACE score to go?
Yes, we will go for it now. Yes, I just,
okay.
Tyson, we will just getting for the GRACE score. Yes, the risk probability, it's differ according to the GRACE, and we will see it now. First, I will go for the monitoring of the patient because it's a new indication. or just modified indication. We have to continuous rhythm monitoring for the non-STEMI patient, and we have to do a rhythm monitoring for more than 24 hours in diagnostic non-STEMI patient and at increased risk for cardiac arrhythmia. And then the risk scores, like you say, now we have the risk scores for prognosis and mortality and risk scores for the bleeding. Or any patient coming to me in the ICU or the CCU, and I have to give what we call the risk stratify the patient in order to give him the proper treatment. And of course, we have to use, and the guidelines insisting about the use of GRACE risk score, which we all use in every ICU or ACC or CCU. And this is a criteria for the GRACE score. We have the Caleb class, and we have stool blood pressure, we have the heart rate, we have the age, we have the creatinine level, and we have other risk factors like the cardiac risk at admission and the ST segment deviation and the elevated cardiac enzymes. Each has its own score according to the algorithm of the GRACE. And then after we adding all the points, we have the total points here. And according to the points, we have the probability of in-hospital death and the in-hospital mortality and the 6 months post-MI mortality. And if we see here, our patient, and this is the guidelines slide about this, clarify how to risk stratify the non-STEMI. It has a class 2A indication. I have to use the GRACE risk score for estimation for the prognosis. And I have to use, it's not I have, it should, or maybe considering use a dual antiplatelet, the DAPT score and the precise DAPT score in order to risk stratify for bleeding. And if we see our patient, he is a male, 55 years old, his heart rate about 125, systolic pressure 90, creatinine 1.7, no cardiac arrest admission, no ST segment deviation. He has normal ECG and he has an abnormal cardiac enzymes. He has a bilateral basal crypts, yes, who has a pulmonary edema, and he has a score of 142. And that means in risk score, he has a high probability of in-hospital death. It's a high-risk patient. And if we see about the post-discharge to 6 months death, he is also a high risk for about 8% death in post-discharge to 6 months. Then after doing this risk score, yes, I have what you are saying or what you are telling us now about the low to intermediate test probability. This is a high risk patient, and I shouldn't use the CT angiography for diagnosis, although I have a normal ECG, but I have a high cardiac troponin level, and that at least lead to increase the risk of the patient in the GRACE risk score and lead to another risk score, which is bleeding. By the way, if we have the GRACE risk score, yes, we have it in the MedCalc. It's a simple application. We have it in all iOS and Android. And the precise DAPT score, it's a very simple calculator. Yes, it's present online also. We use the hemoglobin of the patient, which was in this case was about 13, and the age, the white blood cells, and the creatinine clearance. It can be calculated from MedCalc also. And if they have prior bleeding or not, then I calculate our patient with a low risk of bleeding, and he has a 10 months risk of TEMI major or minor bleeding about 1%, and the 12 months risk of TEMI major bleeding about only 0.5%. So that concludes that I have both the score for prognosis and mortality, and I have the score for bleeding. The new guidelines add another score, which is the ARC score, or Academic Research Consortium for High Bleeding Risk. By including the bleeding risk is high, at least one major criteria or 2 minor criteria. What is the major criteria? The use of long-term oral anticoagulant, the severe or end-stage CKD, hemoglobin less than 11, spontaneous bleeding 6 months before, moderate or severe baseline thrombocytopenia أقل من 100, chronic bleeding diastasis, liver cirrhosis, active malignancy, previous spontaneous intracranial hemorrhage, previous traumatic intracranial hemorrhage, presence of brain AV malformation, moderate to severe ischemic stroke, most of the industrial cases, recent major surgery or major trauma within 30 days prior to PCI. And if we look at the minor criteria, I have to use 2 of them if I have this risk of bleeding at the time of PCI. The age more than 75, moderate CKD, hemoglobin 11 to 13 for men and 11 to 12 for women. The spontaneous bleeding required hospitalization within the past 12 months. It's a minor, not a major. Chronic use of non-steroidals or steroids or any ischemic stroke at any time, it may be considered a minor criteria. So after all of these scores, then I will go.
Dr. Mohab,
I'm ready.
we must admit first that this is a comprehensive score, but it's a little bit difficult. I think it will have sometimes to be applied in the clinical practice. But again, the use of risk score of mortality and for bleeding is important in managing the patient with non-STEMI. So we have a little bit difficult question about when you met a non-STEMI patient. This is from Dr. Celia Dreff. When you met a patient with in the descending limb of troponin values. How would you manage these patients? You have a patient with the first value was maybe borderline, and the next value was going down. How would you manage these patients?
It's a little bit difficult, but I think we will go for in this patient for the observe area. I will not rule out this patient, and I will not rule in this patient for a high risk procedure, and I will observe the patient doing some sort of confirmatory test like non-invasive testing in order to get, and of course the situation like you said in the first, I have to check for the chest pain, I have to check for the ECG, I have to check for the echo, I have to do whatever I am doing for the patient, even he coming after 24 hours from the presentation. Because sometimes we have what we call the missed myocardial infarction and the late presenters. It's abundant in Egypt actually. So we have to be sure that he is in acute coronary syndrome, and we may deal with it according to the guidelines. If I have a high suspicion or a high risk criteria, I will go for the rule-in model. And if I don't have this criteria, like we said in the borderline troponin, it may be increased due to any other cause. Because we have the, like we said, the confounders of troponin and also the cases which increase the troponin concentration, which not due to acute coronary syndrome. So I have to be sure.
So can I rephrase the question, dear Dr. Mohab? So can we consider the rise or fall in the troponin as an alarming sign?
I think it is the changes in the troponin. If I have a high troponin more than normal, it's positive troponin, you said in the first sample, it's enough for rule in. If I have a fall in troponin, actually it may be some sort of changes, physiological or a late presentation, like I said. But if I have a rising troponin, of course, from the start, it's a rule-in model. That depends about the first sample. If you have the first sample is higher than the positive value, 99 percentile, yes, it's actually a acute coronary syndrome. I don't need the. I will use the other sample, but it will not change my decision, like the guideline said. But if I have the normal or nearly normal value at the first sample, I will check for the 1 hour sample and the 3 hour sample, like we said in the slides.
It's not only about the troponin, the clinical.
Like you said, yes.
Clinical picture, ECG, imaging, as you have mentioned, all should include all in the diagnosis of our patient.
Yes, you are a physician, like you said. You are a cardiologist. You don't use only the machines. You have to be aware of all of the other factors, and you have to exclude other causes of differential diagnosis of the acute chest pain. You have to indulge your all experience in order to diagnose and treat the patient as regard this kind of scheme.
So one more question before going to the next part. It's about other bleeding score, has bled and crusade score. Do they have did the guideline mention this score as a bleeding for assessment of the bleeding risk in the non-STEMI?
Actually, no, but for myself, the has-bled score is simple and easy, but it's more related to the use of anticoagulants. Yes. But if we see this precise depth score, it's simple and easy from the CBC with the age and creatinine clearance. I think it will give us some sort of idea about the use of dual antiplatelet therapy and the risk of bleeding, either in minor or major bleeding in the next 12 months. I think it's important to use a simple bleeding score because the guidelines didn't agree about using of a single risk score from the start. We have a different risk scores for bleeding, like this complicated risk score, the new complicated ARC risk score as a major and minor criteria. And I think using the simplest is the best. Has-bled is simple, and has-bled actually I have a paper in validating the has-bled score in the acute coronary syndrome, but it's not still present in the recent guidelines.
So to use one of those, precise depth is a simpler one. And
Yes.
if you want to use the ARC high bleeding risk score, you can do that.
Yes.
Okay. So go, Mohab.
So about the treatment, we have, of course, the pharmacological, the antiplatelet and pre-treatment, peri-interventional anticoagulant treatment, and the peri-interventional antiplatelet treatment, and post-interventional and the maintenance treatment. If we see how we use the treatment, we have to first look for the patient age, sex, race, history of ischemic bleeding events, clinical presentation, if he has a CCS or or ACS, if he has a comorbidity, especially the CKD, diabetes, peripheral arterial disease, heart failure, if he has a co-medication, especially the oral anticoagulation and the drug-drug interactions. And actually, I encourage all the physicians to have some sort of program on their mobile or their lab. And it's not, it's very simple and easy. And if I don't have some sort of uncertainty about the drug-drug interactions because of the bleeding, I may use this kind of application in order to get the drug-drug interactions about the use of antiplatelets with some drugs like the antibiotics or the other and hormonal drugs or whatever, in order to make sure that I give the patient the good antithrombotics. And lastly, we have the procedural aspect. The patient have PCI or CABG doing femoral radial, invasive or conservative, and I should then give an idea about the antithrombotic treatment, either the drugs, the drug dosing, and the treatment duration. And I love this slide in all the presentation because we have two types of thrombus, the tissue thrombus and the platelet thrombus. We have the tissue thrombus and we're starting from the tissue factor here and the vitamin K affecting the creation cascade in this area, and then the prothrombin. We have then the factor 10 active, which are affected by the NOAC and the enoxaparin and the fondaparinux and the unfractured heparin, and then the thrombin, which affect directly by the unfractured heparin and bivalirudin and the bigatran, and then the fibrinogen, which move to fibrin, and this is a tissue thrombus. And then we have the platelet thrombus by the use of dual antiplatelet affecting the thromboxane E2 and the EDB receptors, and then the activation of the platelet aggregation by the glycoprotein 2B3A receptors, and finally the platelet thrombus. So we have the antiplatelet drugs and the anticoagulant drugs. And if we see about the dose regimen of antiplatelet, of course, we have the loading dose of aspirin. It's about 300 milligram, and the clopidogrel 300 to 600 milligram. Prasugrel loading dose of 60 milligram orally. Sorry. And then the ticagrelor loading of 180 milligram. And we have the cangrelor, the new intravenous agent, and the glycoprotein 2B3 inhibitors. We have here in Egypt the iptafeptide double bolus first, and then infusion, then the tyrofibane bolus of 25 microgram intravenous, not intracoronary, over 3 minutes, followed by an infusion over 18 hours of post-iptafeptide and tyrofibane. And then the anticoagulants, we have the unfractured heparin. We have to use the dose of 70 to 100 unit per kg bolus. And when we use a glycoprotein 2B3 inhibitor, we use a lower dose of 50 to 70 unit per kg. And the enoxaparin and the bivalirudin, of course, and fondaparinux. And finally, the newcomer, the rivaroxaban, we have the very low dose of 2.5 milligram per BID in combination with aspirin for long-term treatment. This is the dose regimen of antiplatelet and the anticoagulant in non-ST ACS. And if we look for the antiplatelet, we have different antiplatelets, the clopidogrel, prasugrel, ticagrelor, cangrelor. If we look at the difference, yes, the main difference is the ticagrelor has not a broad drug. The pre-treatment dose and the prasugrel, the newcomer, it's of course, it's a dependent, it's a broad drug, but has only one step of activation. The dose, like we said, it's differ, but the onset of action, it's delayed for the clopidogrel, it's rapid for the ticagrelor, and it's immediate for the intravenous cangrelor, only 2 minutes. And the offset of action, of course, we have to wait for all of the oral antiplatelet, but the intravenous cangrelor only the offset of action is only in 30 to 60 minutes, and this very important during surgery for this patient if I need CABG. That's what we have the delay for the TICA and the crucial rate of 5 days, and we have no significant delay, of course, for the cangrelor. And of course, all of the antiplatelet drugs have limited data in the dialysis patient and the creatinine clearance less than 15 milli per minute. If we look at this new recommendation, the aspirin, of course, will be still in our recommendation as the first antiplatelet drug. Then we use the B2Y12 receptor inhibitor and the prasugrel ticagrelor first, and fluogrel if not present, prasu or tica. And the prasugrel in these guidelines should be considered in preference to tica for non-ST ACS who proceed to PCI, and this is a new indication. And the use of glycoprotein 2B3 inhibitors should be considered for a bailout evidence of no reflow or thrombotic complication, and this is a class 2A indication. It increased in the indication. And the new indication also, we have no, like the old guidelines, we have to confirm that don't use the glycoprotein 2B3A antagonist in patient whom coronary anatomy is not known yet, what we call the upstream glycoprotein 2B3A inhibitor use.
So Dr. Moheb, we have some new news about the anti-thrombotic treatment. I think the use of prasugrel in preference of ticagrelor is one of them. This is based on the ISAR-REACT trial that showed that the prasugrel was superior to the ticagrelor. And I think the other one is the routine pre-treatment of B2Y12 in a patient presenting with non-ST and will go to early invasive strategy. This is a surprising point because we are accustomed to give patients in the AR the loading with aspirin and B2Y12. So if the guidelines, I think, recommend now to not to do that routinely, especially for the patient, will go to early invasive strategy.
Yes, it's actually the last indication not to administer routine treatment with B2Y receptor inhibitor in patient whom coronary anatomy is not known and an early invasive strategy is planned. So if I have a patient in the emergency and I will get the patient to the CAS lab for an early invasive management, I will not give him a loading pre-treatment with B2Y inhibitor according to the recent guidelines. It's a class 3 indication. It's actually some kind of surprise.
But this is not the case for the patient that will manage the conservatively, or if his invasive strategy will be delayed beyond will be delayed. So this patient should receive B2Y
a pre-treatment.
Yes. Okay.
But actually, if you see the guidelines, it has now a class 2B indication. I don't know if it will go for class 3 in these guidelines or what, but I think because there is no trial in this case, but at least, like you said, it's a conservative strategy, give pre-treatment and then go for the other medical treatment. If you have an invasive strategy, no pre-treatment is required.
Can I ask you what is the value of not giving the B2Y12 as a routine pre-treatment for patients with non-STEMI? What is the logic for beyond that?
The logic is if I have an urgent CABG, I am not delaying the patient for CABG, because if I giving a large dose of B2Y inhibitor, I may delay the patient for 3 or 5 days, and that's not the issue here. I have a left main or a complex coronary anatomy or multi-vessel with no PCI cable center or whatever. I think the logic here is not to delay the early invasive strategy, which may be BCI. Yes, I will give the loading treatment here and I will go for BCI, but it's not a BCI, it's a CABG. Yes, I will go for BCI. I will go for CABG safely without losing time from the high dose of the pre-treatment I used because of the instance of major and minor bleeding during the procedure. due to the use of the pre-treatment.
I think the other point that most of international center using now the more potent P2Y12 inhibitor. This is another point in addition to what you have said, and they have a rapid onset of action, as you have mentioned in the previous table. So this would not be a problem if they are decided to go for ad hoc PCR.
Yes, and the cangrelor is a very good example for this, because it starts immediately and its time of offset is about 60 minutes, but we don't have cangrelor still yet in Egypt. But in this situation, I think you and my colleagues have different scenarios in this case of expecting the worst scenario. Yes, we may have a patient for cabbage, and sometimes the surgeon delays the procedure for 1 or 2 days due to the risk of bleeding.
Thank you, Dr. Moheb, and you can go on.
Okay, the pre-interventional treatment, the anticoagulation, I have to give the patient parenteral anticoagulation in addition to antiplatelet during revascularization procedure. I will use unfractionated heparin, like I said before, in the same dose in every patient undergoing BCI. And in case of medical treatment, or I don't have a BCI, or I will delay the BCI, I may use the fondaparinux, but in this case, I have to use a single bolus of unfractionated heparin in case I do BCI for this patient. It's recommended also the discontinuation of parenteral anticoagulation should be considered immediately after invasive approach. And this is a good and important indication with a class 2A indication. Yes, I don't have to give low molecular weight heparin or unfractionated heparin after the invasive procedure. I will stop immediately after the invasive procedure. And the bivalirudin decreased in the guidelines from class 1 to class 2B as alternative to unfractionated heparin, and also the recent recommendation, the crossover between unfractionated heparin and low molecular weight heparin is not recommended. This is about the anticoagulant treatment. And if we look for this slide, we first give the anticoagulation for BCI, then we assess the bleeding risk, whatever the risk score. If I have a very high bleeding risk, I go for aspirin and clopidogrel for 1 month, then clopidogrel. And if I have a high bleeding risk, I go for aspirin and clopidogrel for 3 months, and then go for aspirin only. If I have a low risk of bleeding, I may use aspirin and tica for 3 months, or aspirin and tica, or prasugrel, or aspirin and actually a clopidogrel or ticagrelor or prasugrel for 12 months dual antiplatelet therapy. And either I use, if I use aspirin and tica for 3 months, I will go for tica for the rest of the 12 months, and then further according to the indication. And if I use the dual antiplatelet, I may use it for 12 months dual antiplatelet therapy, and then go for aspirin and tica according to the Pegasus trial, or aspirin and rivaroxaban according to the Compass trial. This is a conflicting evidence here. He gave us many choices, and there is no definite data about what to use or what to continue on the long-term extended treatment. But it depends upon the trials. The rivaroxaban has evidence with aspirin in the patient with coronary heart disease or symptomatic peripheral arterial disease at higher risk of events. And the use of tica 60 milligram BID is used in post-MI after 1 year in patients with high risk criteria like the complex coronary procedure and the diabetic CKD and the elderly patient. But I think the next guidelines of dual antiplatelet therapy or the antiplatelet therapy may clarify this kind of or confusion using the different antiplatelets. We have different plans. You may use, like in this slide, the aspirin and clopidogrel for 1 month or 3 months, or aspirin and tica for 3 months, and then go for tica only without aspirin, and or may use the ordinary dual antiplatelet for 1 year, whatever the type of antiplatelet, and go further with aspirin and rivaroxaban, or go for aspirin and tica low dose beyond more than 1 year. And
Dr. Moheb, if I may interrupt, So now the prasugrel is considered preferred to ticagrelor in any patient with low risk bleeding, even if it's will be continued to 12 months.
Yes, like I said in the previous slide, the prasugrel is now preferred over tica in non-STEMI acute coronary syndrome doing a BCI.
So this was the question of Dr. Hagar, and we have another question from Dr. Muhammad Abdullah about the initiation of P2Y12 inhibitor even in patients that will not be treated invasively, confirmed non-STEMI acute coronary syndrome, but will not be treated invasively for 24 hours, 48 hours, or the invasive strategy will be postponed. So are we still on the old indication to start P2Y12 inhibitor as soon as we are establishing the diagnosis of non-STEMI?
Yes, like I said in the previous slide, it's a class, this slide, it's a class 2B indication still present, the pre-treatment with non-ST who are not planned to undergo an early invasive strategy. Yes, I may use the pre-treatment with P2Y12 receptor inhibitor as a class 2B indication. It's not contraindicated, or if you say it like you said, the medically treated patient, yes, I will use the P2Y inhibitor like the all the guidelines by using either the clopidogrel loading or ticagrelor loading, or if I have the prasugrel, maybe further in the future.
Okay, but this is a downgrade for this indication.
Yes, it's class 2B. Yes, a class 2B. Like I said in the discussion, it may disappear in the next guidelines. Because still we have a control trial in this situation.
Okay, thank you so much.
Okay, let's continue with the risk criteria for a second antithrombotic agent, and we may use this new table in the guidelines in order to give ourselves some sort of a decision making for this kind of patient. Yes, the high thrombotic risk and the moderate thrombotic risk. That's why I use a second antithrombotic agent. If I have a complex coronary artery disease and one criteria of this, we are calling this patient a high thrombotic risk. If I have its diabetes, recurrent MI, multivessel polyvascular disorder, a premature patient less than 45 years, concomitant inflammatory disorder like the lupus, CKD patient, and some technical aspects in BCI like the 3 stents implanted, at least 3 lesions treated, total stent length more than 60 milli, and this is a new table, history of complex revascularization like left main BCI or bifurcation stenting, history of stent thrombosis on antiplatelet and the CTO vessels. This criteria is considered high thrombotic risk, and the moderate thrombotic risk is a simple coronary artery disease, but with criteria the patient is diabetic, polyvascular, recurrent MI, CTD. So if I either have a complex coronary artery disease and a risk enhancer, or non-complex coronary disease with a diabetic patient, I may use a second antithrombotic agent plus the antiplatelet. So invasive or non-invasive. If I treat the patient, I have to first the patient coming to me in the BCI center or non-capable BCI center. If the patient is a very high risk, and we'll discuss it now, I may go for immediate invasive strategy in less than 2 hours. If it's only high risk, I will go for early invasive. Yes, it's called now early invasive in less than 24 hours. And if it is low risk, I may go for selected invasive strategy. So what is the risk? The very high risk patient is the hemodynamically unstable patient, the cardiogenic shock, the recurrent or refractory chest pain, life-threatening arrhythmias, acute heart failure, mechanical complication of MI, ST segment depression in all leads with ST segment elevation EVR, and that's a very high risk criteria in the ECG. I may use this only criteria in determining the patient very high risk. And the high risk patient is the non-STEMI diagnosis, of course, after troponin assay, the dynamic changes in the ST changes in the ECG, resuscitated cardiac arrest, but with no ST segment deviation, because if I have segment deviation of cardiogenic shock, I will move it to very high risk. And the risk to score, and in this patient, more than 140. So anything other than the high risk and the very high risk criteria is considered a low risk patient, and I may go for selective invasive strategy. So our patient have a non-STEMI, and like we see now in this patient, we have some sort of thrombus in the mid LAD with impairment of the flow in the distal LAD. And if we go for a technical aspect in the guidelines, we have some sort of a technical, we all own these technical aspects, but we have to review it when doing the BCI for non-STEMI. The radial artery still approach is the default vascular access. The anticoagulant dose should be adjusted according to the body weight, like we said in the heparin. Proton pump for patient on that strategy, and especially if they have dyspepsia, reflux, age more than 65 years, H. pylori infection, chronic alcohol use, and of course, in patient on NOAC, our colleague Dr. Omar will give us a hint about the use of NOAC with the dual antiplatelet therapy. And how to identify the culprit lesion. This is another aspect of the guidelines. Yes, I have what we call suggestive criteria of acute plaque rupture in non-STEMI. It's not a total occlusion like STEMI. So I have to find some sort of intraluminal filling defect consistent with thrombus or plaque ulceration, like presence of contrast and hazy contour beyond the vessel lumen, or plaque irregularity like margins or overhanging edges or dissection or impaired flow in the artery. And it's actually this data about the pattern of coronary artery disease in non-STEMI. Up to 20% of patients have no obstructive lesions, and this is some kind of surprising. But 40 to 80% of patients have obstructive coronary disease and have multi-vessel coronary artery disease. It's not only a single vessel. The bypass graft failure and left main coronary disease, maybe the underlying condition up to 5 to 10%. 5% bypass graft failure and 10% in left main coronary disease. So it's high index of suspicion, and especially if I have a high risk criteria patient or high risk scenario. The LED is the most frequent culprit vessel in up to 40% of patients, and the culprit lesions in non-STEMI are more often located within the proximal and the mid segment of the artery, and namely here the LED because it's the most frequent. Finally, the recommendation for revascularization, like we said, an immediate strategy less than 2 hours for the high risk patient, the early invasive strategy to the high-risk patient, and the selective invasive strategy for the low-risk patient all have a class 1 indication. And finally, for the delayed or immediate angiography should be considered among hemodynamically stable patient without ST segment elevation in patients successfully resuscitated. So it's confusing, this recommendation also, because I have a cardiac resuscitation and I have no changes in the ECG, and I have a hemodynamically stable patient, so I have an evidence of class 2A in order to do an immediate angiography or delay it. So it's some sort of bit or a little bit confusing. As regards the technical access, I have the radial access is a standard. I have the DES is recommended over bare metal, whatever the scenario. We don't use bare metal stents anymore. It's recommended to base revascularization strategy according to the situation. He didn't give us here some sort of an answer to the question doing the culprit or doing the whole complex procedure. He gave us a detailed that I have to look for the patient clinical status and comorbidities and the other disease. I have to give the heart team approach for this kind of scenario. I use the syntax score. But the immediate BCI for the culprit stenosis doesn't require the heart team consultation. Of course, I would go for the culprit, but doing the other arteries is still a question. And the complete revascularization should be considered without cardiogenic shock, and this is a class 2A indication. Intracoronary imaging should be considered to diagnose spontaneous coronary artery dissection if I have suspected. And the FFR guided strategy of a non-culprit, non-STEMI lesion may be used during the index BCI, but has a class 2B indication. If we sum up our presentation, my colleagues, if you want to discuss something in the intervention or the coronary.
Thank you, Moheb. I think you have mentioned a detailed description of how to manage our patient invasively. I want to stress on the point of complete revascularization. Complete revascularization is still a debate to do with the index procedure or to do as staged. However, in the cardiogenic shock, it is contraindicated to do the complete revascularization. I think we have a question from Dr. Sabrina T. About do we need a FFR for revascularization or routine FFR for revascularization? I think she mentioned. Sorry, the question is about if we have a multiple lesion, should we revascularize them during the first angiography? This is our discussion, or only the culprit lesion and the other lesion during the hospital stay, and about the use of FFR for revascularization of non-culprit arteries. So can you give? I know you mentioned it, but can you give it?
Yes, I would say that, like the guidelines said, we have to base it on the conditions, the patient clinical status, the comorbidities, the renal condition, the geographic lesions, the difficulty, the procedure, the experience of the operator, the syntax score, the presence of contraindication to CABG or the indication for CABG. It's a difficult scenario. If I have to complete revascularize the patient, the patient mustn't be in cardiac shock. If he is in cardiac shock, I can't do a complete revascularization. And about how to, or still it's not clear in order to how to revascularize the other lesions. Can I use FFR? Yes, I may use it, but it's class 2B indication. It's a weak evidence. Can I use other modality for stress testing or something where I may use it during the index hospitalization, or I may revascularize this patient after in a delayed procedure? It's not still clear. We have a trial going for complete revascularization, a trial against the complete revascularization, registry with that, registry against that. So it's not still clear. And I think the American data will appear next in the 2021 about this kind of situation. And maybe we'll have a clear answer on this. But definitely we have some sort of tailored decision according to your experience and your available clinical data about the patient and all the general situation. Like you diagnose the non-STEMI in a comprehensive approach, you will give the decision of complete revascularization in a comprehensive approach.
So again, as you mentioned, one size does not fit all, and we should treat this type of cases case by case, and according to the local expertise and the technique and the patient condition. Yes, thank you, Mohammed.
Yes, finally, I sum up my new recommendation for the guidelines of the ESC 20020. An alternative, the diagnosis class 1 indication, a new recommendation for the ESC 0-1 hour algorithm. It's recommended to use the 0-2 hour with blood sampling at 0 and 2 hour, but it's validated with the 3-hour algorithm if I have a suspicion. And the very important here, I don't have to use any more to routine measures the additional biomarker like the CK, CKMB, and the hard type fatty acid binding protein or others, in addition to the high sensitivity troponin. For the risk certification, it's a new indication for giving the measuring BNB or NT-proNB in the matter of prognosis. As regards the antithrombotic, the prasugrel instead of ticagrelor in patient going for BCI, it's not recommended to administer routine pre-treatment with B2Y receptor inhibitor in patient growing invasively. And the class 2B indication in patient with non-STEMI cannot undergo early invasive strategy, I can give a pre-treatment. And the de-escalation, and this is a new recommendation also of B2Y inhibitor from Braso or ticagrelor, I can give an alternative DAPT strategy, especially for ACS patient, which is not suitable for potent platelet inhibition. And as regards the NWAC, I will leave it for Dr. Omar. As regards the invasive treatment, we have now what we call the early invasive strategy and the selective invasive strategy, the immediate invasive within 2 hours, the early invasive within 24 hours for the very high risk and the high risk, and the low risk, I will go for selective invasive. And the delayed or immediate angiography for the resuscitated patient, it's a confusing recommendation. And the issue of complete revascularization is still, like we said now in the guidelines, has a major inflection. And about the changes in the guidelines, the 2015 gives the rule out protocol class 1, then it returned to class 2A. And the coronary angiography increased from class 2A to class 1, especially in the low to intermediate likelihood of coronary artery disease. There is monitoring up to 24 hours or more than 24 hours for the patient with non-STEMI increase from class 2A to class 1 indication. The risk assessment, it's decreased from the class 1 indication to class 2A indication, and they mentioned the risk score only. The pharmacological treatment by Valerudin, which was a very big surprise according to the recent trial or data, decreased from class 1 indication instead of unfractionated heparin to class 2B indication, and this is a new indication. The B2Y inhibitor administration, in addition to aspirin beyond 1 year, moved from 2B to 2A indication, especially in the high risk of ischemic events and the major thrombotic events, like we said, or the high thrombotic patient, or high thrombotic risk. And finally, thank you for being with you today.
Thank you so much, Moheb. This was a very lovely presentation, and you have a difficult mission indeed to summarize this new data and to apply it into this clinical case. So I'd like to thank you, and please stay with us. We might have some more questions. So we are going now to enjoy with the presentation with Dr. Omar Saleh about the non-STEMI acute in patients with
Thank you very much, Dr. Karim. Can you hear me now? Dr. Karim, can you hear me?
I can hear you. I can hear you. I don't have.
We can hear you, Omar. We can hear you. Please start sharing your slides, please. Omar, can you hear us?
Yes.
We can see your slides now, so go ahead.
Okay, thank you very much for your invite for this nice night. Thank you, Dr. Moheb, for your elegant talk. I think you have gone through all what we need to know in the non-STEMI patients, and it was very comprehensive, so thank you. We now talk about 2 scenarios that has been proposed by the meeting board. And as you know, that there are many presentations that could be deceiving in the non-ST elevation myocardial infarction patients, and they are calling it non-ST elevation acute coronary syndromes apart from the presence or absence of MI. But anyhow, they have been focusing on the importance of the cardiac enzymes and so on. With a wide range of these symptoms and different clinical scenarios, we choose only 2 scenarios. The first scenario is a case with a 65-year-old male patient. He's an ex-smoker. He's non-chronic liver disease on medical treatment. The patient is non-atrial fibrillation on oral anticoagulation. He was on warfarin. He presented to our ER by severe retrosternal chest pain, and on examination, he was hemodynamically stable. His pulse was irregular, and he was very anxious. His epilepsy shows anemia. His hemoglobin was 10.9. Creatinine was around 1.8. All other electrolytes were normal. His troponin was high, and his INR was 1.9. This ECG was done for him outside the hospital. It shows non-specific STT changes, but however, there is, as you see, a irregular pulse, irregular heart rate indicating atrial fibrillation. So the patient was admitted to the CCU. We started anti-ischemic treatment promptly, and then he was referred to the cath lab for coronary angio plus or minus PCI. And this was his coronary angiography. As you can appreciate here, in the LADs, there is long disease calcified lesion. It's a very significant one, almost 99%. And also the LCX, there is, sorry. And also the RCA, there is a long proximal calcified disease. And then we proceed for the PCI. We go through the LAD, balloon stenting, then post-ballooning, and then this was the final LAD. For the RCA, we go also through the R3A. We go with ballooning, then stenting to the RCA lesion. Post ballooning, then this was the last view for the RCA. So, based on this clinical scenario, after you refer the patient for the coronary angiography and you did for him a PCI, and this patient, you know that he is on warfarin, he is atrial fibrillation, he is in need for long-term anticoagulation, what will be the preferred antithrombotic strategy for this? Would you put warfarin, aspirin, clopidogrel for 12 months? Will you put him on warfarin, aspirin, clopidogrel for 1 month, then continue after 1 month as warfarin, clopidogrel? Will you start NOAC in this patient with aspirin and clopidogrel for 1 month, then NOAC plus clopidogrel? Or you will choose NOAC plus aspirin plus clopidogrel for 6 months, then NOAC and clopidogrel? Let's brainstorm ourselves, and what will you choose for this patient? What do you think?
So thank you, Omar, for this nice scenario. I believe there is an important point to be addressed before answering these questions regarding what is the bleeding risk and what is the thrombotic risk of this patient. We have an old data, or have a relatively old data regarding the use of triple antithrombotic, and we have now the new guidelines that address this issue regarding the use of triple and dual therapy. So can you so it's a lot of data to be discussed. So please go on with your slide illustrating what you have done and what the guidelines advises about the anticoagulant in this patient.
Okay.
The votes, by the way, at YouTube, the votes are going for C.
Votes are going for C. That's nice.
Yes.
Well, as Dr. Karim said, we have to go through a lot of data before choosing a strategy for this patient regarding his triple antitherapy or dual antitherapy. And as you see in the guidelines, they have a lot of scenarios for this patient, but first you have to weigh, as Dr. Moheb showed up before, the bleeding and ischemic risk for this patient. So this patient is 65 years old, is already non-chronic liver disease. His hemoglobin now is 10.9, and the patient has no previous bleeding events. So we'll try to go through and see what's better for him. What we need to know for this patient to choose his antithrombotic measures or treatment, these 3 points. The bleeding risk for this patient, the ischemic risk, and you can calculate for him the precise TAP score. The bleeding risk, as Dr. Moheb showed us, has been identified by a lot of scores. The Crusade score, the Haspel score, but they put in this guideline the Academia Research Sensorium high bleeding risk criteria. But actually, they put a sentence after this that this has not been validated yet. I think that they mean that we cannot use it now on clinical grounds. And all the items that has been mentioned before by Dr. Moheb in this patient and in this criteria, as you see here, has been discussed before. Also, the Crusade score, I think, is much more practical than this. A simple score. It's present on the present on the website. You calculate for the patient the basal hematocrit, his creatinine clearance, the heart rate, his gender, signs of congestive heart failure at presentation, rare vascular disease, presence or absence of diabetes, and the systolic blood pressure at the time of assessment. And according to this, it will give you a bleeding score and also estimate the risk for this patient if it's high, low, or moderate risk, and also the rate of bleeding. And this is very simple, it's very easy, and you can apply it easily for these patients, for your patients. Second, the ischemic risk for the patient. Also, there is a lot of criteria that you base your thrombotic risk for the patient. To simplify this, they put 2 risks only, the high thrombotic risk and the moderate thrombotic risk. Complex coronary artery disease and at least 1 criteria for what I'll show you next, or non-complex coronary artery disease and at least 1 criteria. The non-complex, the meaning of complex coronary artery disease has been left for the decision of the operators. Complex maybe they mean that's a very complex lesion, type C lesion with classifications, left main and so, bifurcation and so, and also the risk enhancers that has been shown here. The high thrombotic risk, the diabetes, any multivesic coronary artery disease, if it has premature coronary artery disease, coronary artery CKD with GFR less than 15. Also history of recurrent myocardial infarction, polyvascular disease, concomitant systemic inflammatory disease are the high thrombotic risk enhancer. On the other hand, the moderate thrombotic risk enhancers, the diabetes requiring medication, polyvascular disease, history of recurrent MI, and also CKD. Technical aspects, it means that it's related to the PCI, related to the coronary angiography and PCI for this patient. If the patient, you plan to put at least 3 stents or plan to treat 3 lesions, these technical aspects very important to be put in mind. If the total stent length may be more than 60, history of stent thrombosis or antithrombotic measure treatment, history of complex revascularization before, this means that this patient has high ischemic risk. So by knowing your bleeding risk and ischemic risk for the patient, you can employ the precise depth score. The precise depth score, as Dr. Mohib showed us, is very easy, and you can apply it on the website. You input the hemoglobin of the patient, the age, the white blood count, the creatinine clearance, and if there has been prior bleeding or not, then you calculate, and it gives you directly if the patient will benefit from long-term antithrombotic treatment, and if the patient will develop bleeding. And they have been put a cutoff point of 25. If the score is more than 25, this high bleeding risk. If less than 25, you can employ this for long-term management. Another recommendations regarding the antithrombotic has been mentioned in the guidelines. As we agreed on, if the Shelf-Vasc score is high, the patient is indicated for oral anticoagulations. Also, the patient should be considered treatment may be individualized based on the clinical benefit of consideration of patient's values and preferences. And they put here that in patient who is considered high bleeding risk, you should go directly and early. Invasive coronary angiography should be done irrespective of oral anticoagulation exposure. It means that if the patient has just taken his oral anticoagulation, you should transfer him directly to invasive coronary angiography. Do not wait. Okay, so remain optimal antithrombotic regime. During PCI, what about during the procedure? Parenteral anticoagulation is recommended irrespective of the timing of the last dose of all NOACs. If the patient is on NOACs already and he has already received his dose, you must give him parenteral anticoagulation during PCI, except if the INR is more than 2.5 in patient on warfarin. Also, in patient on indication for oral anticoagulation with warfarin, in combination or aspirin or clopidogrel, the dose intensity of warfarin should be regulated that the INR should be between 2 and 2.5. And the TTR time or time thrombotic range more than 70%. What about the therapeutic anticoagulation with VKA or NOACs? The class 2A, that uninterrupted therapeutic anticoagulation with VKA or NOAC should be considered during the peri-procedure phase. Do not interrupt the anticoagulation. The antiplatelet treatment in these patients who are already on oral anticoagulation, after a short time of triple antithrombotic up to 1 week from the acute event, dual antithrombotic is recommended as a default strategy, using a NOAC at the recommended dose for stroke prevention and a single oral antiplatelet agent. And these single oral antiplatelets they have given for clopidogrel is preferred over ticagrelor and prasugrel during the triple antithrombotic period. Peri-procedural dual antiplatelet administration consists of aspirin and clopidogrel up to 1 week is recommended. There is no difficulty in this. Discontinuation of the antiplatelet treatment in patients treated with oral anticoagulation is recommended after 12 months. It means that after 12 months, you will put your patient on only oral anticoagulation. In patient with warfarin, it means that the patient cannot take NOACs. Clopidogrel alone should be considered in selected patients. It means when the high space score is high or the high bleeding risk is very high for up to 12 months. You can go on with clopidogrel alone, along with the warfarin. When using a rivaroxaban, and you are concerned about the bleeding risk of this patient over stent thrombosis or ischemic stroke, you can give the patient 15 milligram oral, should be considered, I mean, and preference to rivaroxaban 20 milligram oral for duration of continuous single or dual antiplatelets. So rivaroxaban can be used as a dose of 15 milligram when you are concerned about the bleeding risk for this patient over the stent thrombosis risk. In patients with high bleeding risk, the ligatran is as a dose of 110 milligram, not the 150 milligram dose is recommended. And also with patients with oral anticoagulation, aspirin plus clopidogrel for longer than 1 week, you can extend. It means that you can extend the triple antithrombotic treatment up to 1 month in those with high ischemic risk or other anatomical procedural characteristics which outweigh the bleeding risk. It means that you can extend for beyond the 1 week up to 1 month in patients with high ischemic risk. The dual antithrombotic with an oral anticoagulation and with either the ticagrelor or prasugrel may be considered as an alternative to the triple antithrombotic treatment. And this gave class 2B level of evidence C. It means that you can use the dual antitherapy, you can add ticagrelor or prasugrel to one of the oral anticoagulation instead of the clopidogrel. In patients with moderate or high risk of stent thrombosis, irrespective of type of stent use. And you can stop here at the type of stent use because there are a lot of type of stents. In our patients, we choose one of the second generation stents, the Onyx stent, which could receive, this patient can receive a short time triple antithrombotic treatment. And this is very important for these patients. So we transferred the patient to the CCU and we kept him on rivaroxaban, the 15 milligram dose. Remember that this patient has hemoglobin, he is chronic liver disease, so his bleeding risk is maybe high. And we put aspirin 81 milligram and clopidogrel 75 milligram, plus of course the PPI. He was charged the next day. I called him after 1 week and there was no bleeding and no chest pain, and planned for 1 month rivaroxaban 20, after 1 month rivaroxaban 20 milligram and clopidogrel, and then follow up this patient. Okay, and we'll put some.
So Omar, thank you for this lovely presentation. And before going to management of bleeding, there is some questions we should illustrate about the recent guidelines. So if you have your patient on with non-ST acute coronary syndrome and he is atrial fibrillation and in the oral anticoagulant, and you decided an early invasive strategy for him, would you or would you not interrupt the anticoagulation, and would you delay your procedure till achieving or doing a bridging, then doing your invasive strategy, or would you go directly into the early invasive strategy?
Well, according to the guidelines, you do not delay your procedure. You go directly for the invasive coronary angiography and what's planned for them. Okay. But it depends on will you give or not heparin during the procedure. They said that if the patient was on warfarin and his INR is more than 2.5, do not give heparinization. Okay, and if the patient on other oral anticoagulation, you can give heparin without problems. Okay, so you go directly for the procedure. Okay, and you have to define the coronary anatomy for this patient.
And when giving heparin, what is the dose of unfractionated heparin during the procedure?
Well, maybe it's not mentioned like this, but it's go with the 50 to 70 microgram per kilogram.
About 60, yes.
Sorry, unit per kilogram. This would be a more safer dose to be given. And of course, they recommend that they go through the radial approach more than the femoral approach. You go with more conservative, I mean, as much as you can, more conservative management during your procedure to reduce the bleeding events.
What is the greatest dilemma of the management of the antithrombotic after PCI is a triple antithrombotic. So the guidelines, I think, mentioned we can give the antithrombotic for up to 1 week and in some situation up to 1 month. What do you think about the duration of the triple antithrombotic in the patient with non-ST and atrial fibrillation?
Well, actually, they give triple antithrombotic for 1 week. Let's go for the figure we have here.
Yes.
And we'll talk about it. You see here, Well, they give up to 1 week triple therapy. As you see that NOACs or oral anticoagulation plus the dual antiplatelet, the aspirin and B2Y12 receptor inhibitor, preferably as they says the clopidogrel. Beyond 1 month is preferred to go the triple anti-therapy, triple therapy in patients with high ischemic risk, as the criteria we has mentioned before. Okay. In my opinion, you have to tailor that management to each patient individually. You have to close monitor your patient. You have to follow up closely this patient. If you put him on triple anti thrombotics for 1 month, okay, you have to monitor him closely. Okay, but here the guidelines, the triple therapy up to 1 week is the class 1 indication, as you can see here. Okay, that's the point. If you extend the triple therapy, you have to monitor your patient very closely and monitor for bleeding, as we'll say next in these few slides.
Thank you, Omar. Another point when shifting to the triple, from the triple therapy into the dual therapy. Dual therapy meaning oral anticoagulation, preferably NOACs, plus single antiplatelet. So, which antiplatelet would you choose, aspirin or clopidogrel?
Clopidogrel, of course. They mentioned it by clopidogrel, not aspirin. It's preferable to choose the clopidogrel rather than the aspirin during the dual therapy.
So the dual therapy mostly mean the NOACs plus clopidogrel. It is the best combination.
This is the best strategy. It's the safest strategy up till now.
Okay. And the last point, the dose of NOAC with the dual therapy. What's your advice about the dose of NOAC in these patients?
As a standard in NOACs, rivaroxaban is 20 milligram orally per day. Okay, but if you have concerns regarding the bleeding risk for the patient, if the patient has high bleeding risk, his high split score is more than or equals 3, or he has criteria of ACR, the ACR Academics Research Consortium, high bleeding risk criteria. So you can reduce the dose to 15 milligram per day plus the other antiplatelets.
And not 10 milligram.
No, not 10 milligram. I will not go for the 10 milligram.
And of course, we can use the other NOACs such as dabigatran or apixaban or edoxaban.
Yes, but they mentioned by name the dabigatran at a dose of 110 milligram, not the 150 milligram, you know, and the rivaroxaban as a dose of 15 milligram in high bleeding risk patients. You are concerned about the bleeding for them, or the 20 milligram dose. Apixaban dose, you know, that is 5 milligram twice daily, and they didn't mention that you can modify this dose during the dual therapy.
I think the guidelines mention one more point, that apixaban is the drug that's studied in the patient with non-STEMI treated conservatively.
Yes, you are right.
Yes. So you can go with your presentation, please.
Well, we have a few slides about the management of bleeding. Because when I have been through this, it's very important that you may face the patients with bleeding. They put a term that is called the deliberate hypotension. It means that you can leave the patient for some time in hypotension when he's bleeding by doing some resuscitation for him. Do not attempt to elevate the blood pressure. But however, there's no data on the safe period and the risk-benefit ratio in high-risk patients. In our patients, in our cardiac patients, you cannot leave them for a long time in hypotension. So you have to resuscitate your patient directly, and you have to manage bleeding as much as you can very fast. In this diagram, you can see that as the left side here, there are 3 steps. The first step is to assess and identify the severity of bleeding, manage and control the bleed, determine whether and when to restart anticoagulation. In my opinion, these 3 steps are very important, and these 3 steps will give you the optimum management for the bleeding. First, to assess and identify the severity of the bleeding. Does the patient has one of the following factors? Is the bleeding at a critical site? Is the bleeding is hemodynamic, cause hemodynamic instability? Is it clinically overbleeding, which results in hemoglobin decrease of more than 2 grams, or you need to administer more than 2 units of RBCs? Is there any one of these criteria? Bleeding at critical site, they have mentioned some site, including the intracranial, the intraocular, the intraperitoneal, intrathoracic, and also the pericardium. These are the critical sites you have to look for in the patient. So if the patient has one of these, this is considered a major bleeding. If he hasn't one of them, this is a non-major bleeding. Okay, and you can manage the non-major bleeding by answering this question: does this require hospitalization? Does this require surgical procedure intervention or transfusion? If not, you can continue oral anticoagulation and then initiate any appropriate measures to control the bleeding. But if it requires hospitalization and intervention, you have to stop your oral anticoagulation and initiate appropriate measures to control the bleeding. On the other hand, if it's a major bleeding, you have to answer this: is the bleed at a critical site of life-threatening? If so, you have to stop, initiate appropriate bleeding, and administer reversal agent to control the bleeding and stabilize the patient. But if the bleeding is not at critical site or not life-threatening, so stop your oral anticoagulation, of course, initiate appropriate measures to control bleeding, but look and wait and see if this controls the bleeding or not. If it controls the bleeding, it's okay. If it's not control the bleeding, so you have to administer reversal agents. The next step after you control the bleeding and you stop the bleeding, you have to ask yourself, does the patient need to continue the oral anticoagulation or not? If no need to continue the oral anticoagulation, so discontinue the anticoagulation. But if the patient need to continue oral anticoagulation, you have to answer this: that the patient has one or more following factors applying: bleed occurring critical site, patient at high risk of rebleeding or death severity with rebleeding, the source of bleed has not yet been identified, surgical or invasive procedures are planned, patient does not wish to restart oral anticoagulation at this time. If one of these applies, so delay the restarting of the anticoagulation. If no, suggest the restart of anticoagulation. If you follow this flow chart, you can control the bleeding, you can restart the anticoagulation safely, and then you put the patient for the strategy. What the guidelines said in this: in patient with dabigatran associated ongoing life-threatening bleeding, you can administer the specific antidote for dabigatran, which is the elrasuzumab. You can give it for the patient. In the patient with warfarin-associated life-threatening bleeding, rapid reversal with 4-factor prothrombin complex concentrate. 4-factor prothrombin complex concentrate, rather than with fresh frozen plasma. If you don't have factor prothrombin complex concentrate, you can go fresh frozen plasma, no problem. Or recombinant activated factor 7 should be considered. In addition to this, in patient with warfarin life-threatening bleeding, you can give 10 milligram IV doses of vitamin K by slow injection. In patient with NWACS associated ongoing life-threatening bleeding, the administration of prothrombin complex concentrates or activated prothrombin complex concentrates should be considered when specific antidote is unavailable. And as you know that there has been a new antidote for the rivaroxaban, apixaban, and deoxaban, which is nixanet alpha, and you can consider it if you have it here. Well, I don't have it here, I think. In patient with anemia and no evidence of active bleeding, blood transfusion may be considered in case of compromised hemodynamic status when the hematocrit less than 25% or hemoglobin level less than 8 grams per deciliter. And these were the guidelines criteria for the management of bleeding when giving the antidotes for anticoagulants. And this we sum our patient, first patient, and we'll go through for the second patient.
Yes, thank you, Omar. Go please for the second case.
Okay. Our second patient is a 53 years old female patient. She's obese, she's hypertensive. She came to the ER after loss of consciousness that was preceded by acute dyspnea. Brief CPR was done at the scene and she was transferred to the hospital by the ambulance. When she presented to our ER, she was conscious, slightly confused, but oriented. There was mild chest pain. Her blood pressure was very high, 170 of 110. Heart rate was around 110, 115, and there is no abnormality in the chest and heart. Her laboratory was all normal except for high troponin level. Sorry for the quality of the ECG, but this was the initial ECG in the ER. And as you see, this sinus tachycardia. There is no specific change you can see in the ST or T wave. But later on, when we did another ECG in the ER, you can appreciate that there is ST segment elevation in lead 2, 3, and also in the AVF. Again, sorry for this quality, but this was her ECG. We transferred the patient directly to the CCU and did another ECG for her. And as you see that there was just a transient ST segment elevation and not persistent. So the patient was admitted. Sorry, this is our question. What will be the next step for this patient? Do you activate the cath lab immediately and perform coronary angiography where you conserve medical treatment and follow up? Or you start treatment and plan for angiography later on? What do you think we should do for this patient? Okay, we can move on to see the guidelines. What does it say? In the management of patients presenting with resuscitated cardiac arrest needs to be individualized. According to what? According to the hemodynamics and the neurological status of the patient. In out-of-hospital cardiac arrest at no ST segment elevation without cardiogenic shock, in the Cook Act trial showed no superiority of immediate invasive strategy over a delayed invasive one. And this trial created this recommendation that the delayed as opposed to immediate angiography should be considered among hemodynamically stable patients without ST segment elevation successfully resuscitated after out-of-hospital cardiac arrest. And also, as Dr. Moheb showed us, here in the patient with high risk, the resuscitated cardiac arrest patient without ST segment elevation or cardiogenic shock should go through early invasive strategy, not the immediate invasive strategy. So when the patient is referred to the CCU, we start IV nitroglycerin and enoxaparin along with other anti-ischemic treatment. In the following morning, she was pain-free, her blood pressure was controlled, heart rate was around 80, and she was referred to the cath lab for coronary angio and plus or minus PCI. This was her coronary angiography. As you can appreciate here, there is a long OM branch disease, and here the LAD we have mid-segment lesion. The RCA also we have proximal lesion, so we have 3 vessel disease amenable for PCI, and you can do it on table. We started already. We started with the LCX, ballooning, then stenting, and then this was the final LCX. We shift for the LAD, direct stenting for the LAD. Sorry. And this was the final LAD. Also the RCA, we shift for the RCA, direct stenting for the RCA, and then we go. This was the final RCA lesion. So it's very easy, very simple, and the patient was transferred to CCU again, was kept on dual antiplatelet therapy and other full anti-ischemic measures, discharged next day with no complications. A very short case, illustrating what we have our message, and thank you very much.
Thank you, Omar, for these very nice 2 cases. And I think the second case showed what the guidelines told us about the patient of out-of-hospital cardiac arrest without ST segment elevation. If we have an ST segment elevation, so we should go to the cath lab. But if we don't have an ST segment elevation, we can reserve this patient for early invasive strategy, and we can follow his hemodynamic and watch him closely, be ready to intervene as soon as possible, but the delay is comparable to the early invasive strategy. So there is a question from Dr. Ahmed Saber about the use. We mentioned the NWAX and clopidogrel. So he asking about the use of clopidogrel with warfarin. I think he asking about this combination because we mentioned that the best combination is NOAC and clopidogrel. So what do you think about warfarin and clopidogrel, Omar?
Okay, you know that still we have the indication for warfarin, which is the prosthetic valve patients. You cannot give them NOACs. And if the patient cannot afford the NOACs, you have to give him warfarin. Okay, the guidelines said that you have to keep the patient on the target INR 2 to 2.5, not more than this, not to exceed 2.5, okay? And to monitor the time in therapeutic range that should be less than, not less than 70%. This is very important. If the patient exceeded the time on, exceeded the INR, bleeding risk may be high. So there is nothing we can do. You have to give the patient a Minivan. You can keep the INR like this, between 2 and...
I think, Omar, the patient with a stable INR on warfarin and maybe due to logistics and cost issues, they can continue on warfarin in addition to the single antiplatelet. However, if the INR is unpredictable and fluctuating, so we should shift to the NOAC for the risk of increased risk of bleeding and for the safety of these patients.
Of course, yes, I agree with you. Yes.
Okay, so Omar, thank you so much again for this nice illustration of how to manage the patient with a triple antithrombotic and the patient with out of hospital cardiac arrest. And now, and please also stay with us, and we might have some other question for you. So I'll show the last part of this webinar, which is the myocardial infarction with non-obstructive, with non-occlusive coronary artery disease. So the guidelines mentioned this part again, the minutia, which is a very important part. And this is a case of a 44-year-old female. She is obese with no risk factor. She is not diabetic or hypertensive, presented with cervical and spinal pain associated with dynamic segment depression in the precordial and might be elevated opponent air echo cardiography with normal fraction and no normality. And coronary angiography was done immediately for her and reveals non-occlusive. There was no occlusive coronary artery disease. So despite having elevated cardiac troponin, there was no occlusive coronary artery disease. And this is her right coronary angiography. So the guideline is initially considered as a time we did angiography and basic angiography for a patient with non-TI syndrome, and found that angiography is normal. So we started to think about the minutia as working diagnosis. Until further assessment excludes other possible causes of troponin elevation. It was these causes were mentioned by Dr. Muhammad in the first presentation. The risk factors for the minutia is more likely to be among the younger and the female patients, and less likely patients who have risk factors such as diabetes mellitus, hypertension, and dyslipidemia. Regarding their prognosis, there are a lot of different studies regarding the inclusion criteria and the outcome. With better prognosis than obstructive coronary disease is mentioned in this study. However, we have a lower survival rate than healthy disease. So, to diagnose the myocardial infarction with non-obstructive coronary arteries, we should have at first myocardial infarction, and this is according to the fourth universal definition of myocardial infarction. That depends on the definition of the rise or of cardiac troponin above the 99th percentile power reference limit, together with clinical evidence of infarction, such as symptoms, ECG changes, Q waves, imaging evidence of such as or abnormality, or coronary thrombocyte coronary angiography. we should also have an non-obstructive coronary artery angiography, which means that we don't have atomic stenosis more than 50%. And this is a case only with normal mild pulmonary crisis or coronary stenosis is considered among the definition of minutia, and we should exclude other and then using guidelines that they exclude the myocarditis and cardiomyopathy from diagnosis of myocardial infarction or non-occlusive coronary disease. So we should have a myocardial definition, a myocardial infarction with non-occlusive coronary disease and absence of other diagnoses. And this is a traffic light chart, and that was suggested by the guideline for diagnosis of minutia. First, we should have, as mentioned, a rise of troponin with signs, symptoms, and non-obstructive coronary disease. And we should have an assessment of the left ventricular function, either with echo or left ventricular angiography. If we have clinically any other causes that explain the patient picture, such as pulmonary embolism, aortic dissection, sepsis, or other causes of pulmonary embolization, we will exclude the diagnosis of minutia. Otherwise, we should continue the minutia as a working diagnosis, and we are very important to include angiography to detect any obstructive.
Can you hear me?
Yes, Muhammad. Yes.
I think there's something wrong with your connection because your voice is glitching, and the people on the YouTube are saying that they cannot hear you properly.
So can you hear me? So it's okay.
Maybe you can switch off the video.
Yes.
So all the connection is going to the audio, please. Switch off your camera. Yes, start sharing your slides. Maybe you can go 2 or 3 slides backwards, please.
So do you hear me, Zahra, now?
Yes, it's clear now, Karim.
Okay, so let me share you my slides again.
So Karim, why are you sharing the slides?
Yes, where did you miss me, Haitham? So,
just 2 or 3 slides before. So you can start the algorithm all over again.
Okay.
Okay, so before starting the algorithm, there is a question to clarify before going into the algorithm, the difference between minutia and a small vessel disease asked by Dr. Hagar. What's the difference between microvascular coronary artery disease and minutia?
Okay, I think they are different entities. Maybe there may be some overlap, but they are different entities. The minutia is an acute situation with elevation. We must have an elevation of the cardiac troponin and evidence of myocardial injury. The microvascular disease is limited to patients with chronic stable angina, and this is one of the categories of chronic stable angina. So if we have elevation of the cardiac enzymes, this is the minutia and the other alternate diagnoses. And if we don't have, we might search for a microvascular disease as the cause of the patient's symptoms. So again, going to the traffic light algorithm. This algorithm for evaluation of the cause of the patient symptoms. We start with, we have a patient with a definition of myocardial infarction with elevated cardiac troponin together with the symptoms and signs, and the coronary angiography showed non-obstructive coronary artery disease. Then we have an LV functional assessment by either by echocardiography or the left ventricular angiography. At this stage, we may reach clinically to diagnoses that exclude the minutia, such as pulmonary embolism, sepsis, and aortic dissection. And of course, these diagnoses needs a clinical context, needs some labs investigation. For example, in the pulmonary embolism, we need a D-dimer, and we may go to pulmonary CT angiography. If we don't have any of the other diagnoses with red, we go into the yellow. With yellow, we should work with a minutia as a working diagnosis. First, we should review the angiography for any missed findings, such as obstructive coronary artery disease or spontaneous coronary artery dissection. This can be missed in the coronary angiography. The other thing is to differentiate between the ischemic and non-ischemic pattern of minutia. And cardiac magnetic resonance can help greatly in differentiating these two categories. These guidelines included the COSU and myocarditis and consider them as a specific non-minutia diagnosis. So the cardiac MRI showed evidence of a myocarditis or edema of the COSU. This can help to exclude the minutia. However, if we have a subendocardial leg delirium enhancement, we should continue our diagnosis as a coronary artery disease and minutia. And this will go help us to go into the minutia and the ischemic lesions of minutia. As we mentioned, we might have non-obstructive plaque and spontaneous synchronization of a thrombus, or we may have spontaneous coronary artery dissection or even intracoronary stent. And we can use another imaging and other physiological assessment of the coronary for evaluation of these types of pathology, such as the intravascular imaging using IVUS or OCT. It can help to differentiate and to detect the black morphology and the black rupture or the presence of spontaneous coronary artery dissection. Also, we can inject intracoronary some vasospastic agents such as acetylcholine or ergonovine that help for identification of the coronary artery spasm. One of the categories that mentioned in the guidelines is the spontaneous coronary dissection, which is a non-atherosclerotic, non-traumatic, atherogenic separation of the chronic arterial tonics secondary to vasovasorum hemorrhage or intimal tears. This creates a false lumen, coronary compression, and causing myocardial ischemia. Its incidence about 40% of acute coronary syndrome cases, but may be higher in the female less than 6 years with pregnancy and with some disorders such as fibromuscular dysplasia, depression, and anxiety. Usually, these patients present with myocardial infarction, and we have these three types of spontaneous coronary dissection. Type 1 with a multiple reducent lumen, type 2 with a long diffuse lesion, and type 3 with a focal tubular lesion. The guideline also recommended the management of the SCAD based on this algorithm. So any of the three times can cause obstruction and reduce coronary flow. In this case, we might go into PCI, taking into consideration that it will be a complex procedure with suboptimal results, or may send this patient to a cabbage. But of course, we will do that only when the patient have evidence of a severe myocardial ischemia. And on the other hand, the patient may have an obstruction with a normal coronary flow or non-obstructive coronary flow. As we mentioned earlier, we can use the intracoronary imaging for a better evaluation of the SCAD. And if we detect the SCAD with with normal coronary flow, we should start the medical treatment for this patient. The mainstay of medical treatment here is the beta blocker, and the dual antiplatelet is questionable regarding its use in the patient with SCAD. We will go after that. We can go into the invasive strategy if we have a high risk anatomy, meaning a proximal lesion or multiple SCADs, or if the patient have a persistent or recurrent symptoms despite medical treatment. This is the last part to be mentioned, and this is an important point regarding the Manuka. If we have no obvious cause, we should go for cardiac magnetic resonance as a class 1 indication. For the treatment, if we have an established underlying cause, meaning we have a ruptured plaque, we have a SCAD, we should go for a disease-specific guidelines. But if we don't have a cause, we can go as this is a case of atherosclerotic disease and managing as a secondary prevention guideline. Our patient have a coronary artery spasm, and we know that by making a very simple thing, which is revising the history. By revising the history, this patient have had migraine, and she got an conservative treatment that was known to cause intravascular spasm and especially coronary spasm. And with stoppage of this medication, the patient was symptom-free and there is no further attack. So this is the conclusion for the Manuka in these guidelines. We should follow the traffic light algorithm and the cardiac magnetic resonance if no obvious cause, and we should treat according to the cause as we mentioned that in the algorithm. And thank you so much.
Thank you, Karim, for this very elegant presentation. I have a question myself. I wonder if why the guidelines did not mention the role of multi-slice coronary CT or the CT. There was a trend, especially in the high-tech multi-slice CT machines, to have a triple workup to exclude the pulmonary embolism, coronary artery disease, or aortic dissection in patient whose diagnosis is not obvious. So did the guidelines mention any of this technique in excluding Manuka or other causes of elevated troponin in these patients?
So thank you for your question. Number one, as you know, the CT is more reserved for the patient with low to intermediate risk, and these patients have elevated cardiac troponin. So it's relatively a high risk, and we should have an assessment mostly by invasive coronary angiography. The second point regarding the triple rule-out strategy, it is associated with a very high contrast load and a very high radiation dose, and it should be reserved for when there is a very big possibility of having the three diseases together. And actually, when asking the expert in the multi-slice CT, they usually don't do that because it needs different phases to evaluate all the vascular beds. So the triple rule-out, despite it was mentioned earlier, I think its role is declining now, and we should depend on the clinical context. And if we have the Manuka, I think the cardiac MRI would give an idea about the different diagnoses better than any other imaging modality.
Okay, thank you so much. Do we have any other questions?
Thanks a lot, Karim.
Actually, I have one question, please.
Yes, please, Dr. Omar, go.
Sorry to Mohammed. Dr. Karim, do they mention to do challenge tests during coronary angiography or during whatever challenged by acetylcholine or something like this? I didn't catch it during the presentation. Did
Yes.
they mention this?
Yes, I mentioned that. If you have this here in the algorithm.
And
here in the algorithm, yes, and the going to the green area, which is the minuca, is the diagnosis now, and we want to know the ischemic reason for the minuca. One of the most important reason is the coronary vascular spasm, and it can be only detected using the intracoronary functional testing using the acetylcholine or ergonovine.
Yes, and this is class 1 indication.
Yes, it's a class 1 indication if you are suspecting spasm, if you are suspecting coronary vascular spasm.
Okay, yeah.
However, they don't mention when to use the intravascular imaging and when to use the intracoronary spasm, and left it for the operator preference, which etiology would he suspect more.
So you mean that any choice from this could I can use the or using the
one of them or
yes.
the both of them according to I think it should also, as we mentioned in a lot of points today, it should be tailored according to the clinical scenario. However, the best imaging for the best thing to do for the black rupture or coronary emboli or thrombi is the vascular imaging, and the physiology for if we are suspecting a microvascular spasm or microvascular disease.
Yes, yes. Thank you very much. Very elegant lecture. Thank you.
Thank you, Omar. Thank you, Omar. So I think, Aysam, we have some question for...
we have a question, Dr. Mohib, yes.
Yes.
It's the use of rivaroxaban after 12 months instead of ticagrelor in patient with non-STEMI acute coronary syndrome after ending the 12-month P2Y12 inhibitor. Can we use the rivaroxaban instead of the ticagrelor?
Actually, yeah, according to the guidelines which are seen now, it's some sort of conflicting evidence. Like you see, if we follow up this guidelines, we have too many options. And I think, like my colleagues said here, we have to tailor our therapy with each patient. For myself, I prefer to use dual antithrombotics, antiplatelet and antithrombotic in secondary prevention like the COMPASS trial. But if I have a high-risk anatomy, for example, a left main patient, a complex procedure like CTO or a bifurcational lesion, I will continue for ticagrelor, according to the Pegasus trial. It's not a conclusive, don't have a conclusive evidence if we have done a comparative trial or a RCT comparing long-term rivaroxaban versus long-term tica or long-term antiplatelets. But I think it's some sort of a tailored therapy. For myself, like I said, if I have a left main lesion, if I have a CTO, if I have a bifurcational lesion, I will go for tica, even low dose for the high risk or patient of bleeding, 60 milligram. And if I don't have some sort of like this, I will go for rivaroxaban 2.5 twice daily plus aspirin.
I think the guidelines left it for, as you mentioned, for the operator and for the physician regarding the long-term antithrombotic agent. Yes. Either to use the rivaroxaban 2.5 twice according to COMPASS trial, or the ticagrelor 60 milligram once according to the Pegasus STEMI 54 trial. So it depends on these patients have a high thrombotic risk, and to go with a dual antithrombotic for longer duration, either with these two agents according to your preference.
Your patient, yeah, physician discretion, yes.
So, Zahran, do you have any other, you want to ask any other thing?
No, and there is...
Thanks a lot, Karim and Aysam, Mohib and Omar, for this very, very, very educative webinar, actually. All of you did a great job. We got the case-based discussion by Dr. Mohib at the beginning, where we went through the guidelines, and then Dr. Omar completed the job, and then Dr. Karim gave us the hints about Minuka. We had a very good interaction from the YouTube from all over the world, actually, tonight. This was a very, very well-planned webinar. Next Saturday, we will be discussing the adult congenital heart disease, grown-up congenital heart disease guidelines, which was also published by the European Society of Cardiology 2020. And we will have elegant national and international speakers on board. And next Thursday, we will be discussing the atrial fibrillation guidelines, and we will be hosting a consultant from England to discuss with us, specialized in the field of electrophysiology, to be discussing with us the new guidelines also in the form of case-based discussions. So I would like to thank Dr. Muhib Wadia for joining us tonight, Dr. Omar Saleh also for his elegant contribution, Dr. Karim Mahmoud for his great lecture, and Dr. Haitham Suleiman for moderating with us all the questions from the YouTube channel. And I would like to thank the whole CEC board, and see you next Saturday, inshallah.
Thank you, Mohammed. Thank you.
Thank you.